Occupational English Test. Listening Test. This test has 3 parts. In each part you'll hear a number of different extracts. At the start of each extract you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for extract 1. Extract 1. Questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, Mr. Kevin Moore. I'm Dr. Benson. What brings you in today?
Good morning, Dr. Benson. Recently, I've been experiencing some concerning changes in my vision. For about a month now, my night vision has significantly deteriorated, making it hard to see in low light. Also, I've noticed a decrease in my peripheral vision.
Thank you for sharing that, Mr. Moore. It's important we take a thorough look at your medical history first. Have you or anyone in your family experienced similar symptoms or been diagnosed with any eye conditions?
I personally haven't had any major eye issues before. However, my grandfather had an eye condition in his later years, though I'm unsure of the specifics.
Understood. Have you noticed any other symptoms such as difficulty adapting to darkness or perhaps an increase in floaters or flashes of light?
Now that you mention it, yes. Adapting to dark environments takes much longer than it used to. And I do see floaters occasionally, especially when I'm outside in bright sunlight.
These symptoms could be indicative of retinitis pigmentosa, a group of genetic disorders that affect the retina's ability to respond to light. I'm going to suggest a comprehensive retinal examination, which will include a fundus examination, visual field testing to assess your peripheral vision, and possibly an electroretinogram to measure the electrical responses of your retina's light-sensitive cells. After completing the examination and analysing the test results, it appears you do have retinitis pigmentosa. This condition is characterised by the progressive loss of rod cells in the retina, leading to diminished night and peripheral vision.
That sounds quite serious. What steps can we take to manage this condition?
Currently, there is no cure for RP, but there are several ways we can manage the symptoms and aim to slow down the progression. Vitamin A palmitate supplementation has shown promise in some cases. However, it's essential to monitor liver function regularly due to potential toxicity. We'll start with a lower dose and monitor your response.
Are there other lifestyle changes or treatments that could help?
Absolutely! Protecting your eyes from UV light is crucial, so I recommend wearing protective sunglasses whenever you're outdoors. A diet rich in omega-3 fatty acids found in fish and flax seeds can be beneficial for overall eye health. Regular aerobic exercise has been shown to improve blood flow to the retina, which could be beneficial.
What about changes to my daily activities?
As RP progresses, you'll need to make adjustments for safety, especially in low-light environments. I recommend exploring adaptive technologies like text-to-speech software and mobility training with a specialist. We'll also discuss occupational therapy options to help you adapt your workspace and home environment.
And what about regular checkups and follow-ups?
We'll schedule regular appointments every 6 months to monitor the progression of your condition. It's also crucial to have a comprehensive genetic counselling session, considering the hereditary nature of RP. This can provide valuable information for your family regarding genetic testing and future planning.
I appreciate all this information, Dr. Benson. It's a lot to process. but I'm relieved to have a clear plan moving forward.
Warmly. You're very welcome, Mr. Moore. My goal is to support you every step of the way. We'll work together to manage your condition effectively and maintain your quality of life. If you have any questions or concerns, please don't hesitate to reach out.
Extract 2. Questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, Mrs. Sarah Turner. I'm Dr. George. Please tell me more about the symptoms that bring you here today.
Good morning, Dr. George. Over the past few months, I've been battling with persistent heartburn. It's particularly troublesome after meals and has been disrupting my sleep. I've also noticed an acidic taste in my mouth and occasional difficulty swallowing.
I understand. Symptoms like these are often associated with gastroesophageal reflux disease, or GERD. This condition occurs when stomach acid frequently flows back into the tube connecting your mouth and stomach, irritating the lining. Let's delve into your medical and family history. Have you experienced similar issues in the past, or are there any known gastrointestinal conditions in your family?
I've had occasional heartburn in the past, but nothing as persistent as this. As for my family history, my father had some kind of ulcer condition, but I'm not sure if it's related.
Interesting. Now, let's discuss your lifestyle and diet. Dietary habits can significantly influence GERD symptoms. Do you consume caffeine, alcohol, or spicy foods regularly? What about your eating patterns and meal timings?
I do have a cup of coffee daily and occasionally spicy food. My meal times are often irregular due to my work schedule.
Irregular meal times and certain foods can exacerbate GERD symptoms. We'll address these factors in your treatment plan. Now, regarding diagnosis, I recommend an upper endoscopy. It's a minimally invasive procedure that allows us to look inside your esophagus and stomach for signs of damage from acid reflux. It's a key step in confirming GERD and ruling out other potential issues.
Is the procedure safe? What should I expect?
Upper endoscopy is a safe and routine procedure. It involves sedation, so you'll be comfortable throughout. A thin, flexible tube with a camera at the end, called an endoscope, will be gently guided down your throat. This allows us to visually inspect the esophagus, stomach, and the first part of your small intestine. If necessary, we can take small tissue samples for further analysis.
I see. That sounds thorough.
Regarding treatment, we'll start conservatively. Lifestyle modifications are crucial. I advise avoiding foods and drinks that trigger your symptoms. We need to establish regular meal times, and it's best to avoid eating close to bedtime. Elevating the head of your bed can reduce nighttime symptoms. As for medication, I'll prescribe a proton pump inhibitor, PPI. PPIs are effective in reducing stomach acid production, which helps heal the esophageal lining and relieve symptoms.
Are there any risks or side effects with these medications?
Like any medication, PPIs have potential side effects. Long-term use has been associated with an increased risk of vitamin B12 deficiency, bone fractures, kidney disease, and possibly gastrointestinal infections. We will carefully monitor your treatment and make adjustments as necessary. If conservative measures and medication do not effectively manage your symptoms, we may consider surgical options, such as a Nissen fundoplication. This procedure involves wrapping the top part of your stomach around the lower esophagus to strengthen the barrier against acid reflux.
I appreciate this comprehensive approach, Dr. Johnson.
You're welcome, Mr. Turner. Managing GERD is a combination of medical treatment and lifestyle adjustments. Regular follow-up appointments will be crucial. We'll monitor your progress and make any necessary changes to your treatment plan. If you have any questions or if your symptoms change, please contact me immediately.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear an A&E doctor briefing a colleague about a patient. Now read the question.
Mrs. Mason, a 32-year-old woman, came into the A&E last night for a mildly itchy rash on both legs that had been ongoing for 3 days, as well as lower extremity joint pain and abdominal pain. She informed me that she has had a winter cold for about 1 week and has been taking over-the-counter cough medication for her symptoms. She told me that she suspected that the rash may be the result of an allergic reaction to the cough medication, but that the rash worsened after she stopped taking the medication. She said she has not had fever, diarrhea, vomiting or other symptoms. Lab results and a chest radiography are normal. I'm going to call for a dermatology consult.
Question 26. You hear a dermatologist in a training session with an intern. Now read the question.
So, Sarah, what do you know about your patient?
Patient is a 67-year-old man presenting with 2 nodules on his left elbow. He has no history of skin conditions but was diagnosed 2 years ago with rheumatoid arthritis, which he manages with non-steroidal anti-inflammatory drugs. The nodules are uncomfortable and aesthetically displeasing, but they're not causing the patient any pain.
What do you recommend as the next step?
During my examination, I noticed 2 large, firm, skin-coloured, subcutaneous nodules. I recommend performing a biopsy to check for rheumatoid nodules.
What is the cause of rheumatoid nodules?
Rheumatoid nodules are...
Question 27. You hear an intern asking a senior doctor about the diagnosis of a patient. Now read the question.
Dr. Norris, I have a question about the patient with the long-term ongoing tremor. Shouldn't we be considering Parkinson's disease as a possible diagnosis?
Yes, it is a consideration, but there are a few symptoms you should look closely at to differentiate between the 2 diagnoses. For example, the patient has been experiencing a hand tremor for quite a while, but he also has a head tremor. Also, the overall health of the patient is good. Patients with Parkinson's disease often have other problems. Do you know what those are?
Oh yes. Stooped posture, slow movement, memory loss. Thank you for helping me to look more closely at the symptoms.
Question 28. You hear a morning briefing in a ward. Now read the question.
Now we come to Mr. Jenkins, who came into the psychiatry A&E department last night. Cheryl, can you present the case, please?
Of course, Dr. Scott. The patient is a 40-year-old man who presented with inappropriate behaviour and confusion. According to his records, he has appeared fidgety for several years. A neuroconsult found him to be alert, but easily distracted. He also had problems spelling world backwards, but demonstrated no short-term memory problems. With ambulation, jerky movements are present in the hand and his balance is altered. A urine drug screen came back negative.
There seems to be a lot we don't know about the patient. Cheryl, please get a full medical history on this man as well as his family. Then, depending on what we find out, we can move on to tests. Now.
Question 29. You hear two radiologists discussing the possible diagnosis of a patient. Now read the question.
I have a case of a 53-year-old female complaining of a sore throat, difficulty swallowing, and the sensation of a lump underneath her tongue. She was referred to me by her GP, as it appears that the symptoms have been worsening over the past few months. I ordered a CT, as plain radiographs showed nothing.
Let's take a look at the scans. Oh, that's interesting. Do you see that? There appears to be a bony outgrowth arising from the base of the temporal bone of the skull.
That could definitely be the cause of the symptoms of this patient. Have you ever seen a case of Eagle syndrome?
I think when I was an intern.
Question 30. You hear a patient expressing a concern to an occupational therapist. Now read the question.
So today we're going to conduct an occupational therapy assessment to see what your needs are. I can see that you have progressed to fully weight-bearing and that you are using a walking stick.
Yes, it has been a long journey since my accident. I have started to use the stairs by relying on one handrail and my walking stick.
What are your main concerns now, Sheila?
I really want to be able to get into a bath to shower. I have tried, but stepping into the shower is very painful. Also, I'm not able to use my right arm to reach out and support myself when getting into the bath. Pain in my leg and the problem with my right arm makes me nervous about showering.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear part of a presentation on training opportunities in dentistry. You now have 90 seconds to read questions 31 to 36.
So today I'm honoured to present Dr. Nijad, who is an internationally recognised specialist in restorative and aesthetic dentistry, and who works tirelessly to inspire passion in the art and science of dentistry and mentor future generations of dentists to lead the profession. And Dr. Nijad will discuss the training opportunities available in these two areas of speciality. Please join me in welcoming Dr. Nijad.
Hello everyone, and thank you very much for that kind introduction. I am indeed very passionate about inspiring and mentoring future generations of dentists, and a key part of that is promoting the understanding of the remarkable properties of the natural tooth, including aesthetics, function, strength, and biomechanics. I seek to promote these areas through taking an active role in scientific research, as well as developing and delivering advanced training courses for practicing dentists. As Dr. Sampson just mentioned, I'm going to talk about training courses in restorative and aesthetic dentistry. So first I'm going to talk about restorative dentistry. And the first thing to mention is the approach that we take, which is a biomimetic approach. Using this approach, course participants will learn how to preserve intact tooth structure while restoring teeth to function and restoring strength. I'm going to take just a moment to explain a bit of the difference between this approach and traditional dental procedures. Traditionally, dental procedures rely on preparation designs that accommodate the restorative material or technique. This includes preparation features such as retention and resistance form, as well as tooth reduction to meet the strength requirements of the restorative material, instead of prioritizing the preservation of intact tooth structure. And the result of this is that the restored tooth has significant additional preparation and a significantly higher chance of complications such as post-op pain, sensitivity, root canal treatment, recession, as well as fracture. As I have already alluded to, the biomimetic approach unites an understanding and appreciation of the biomechanics of natural teeth with principles and techniques that maximize adhesion. The restorative materials used in this approach replicate the properties of the dental structure, and so healthy intact tooth structure is preserved through adhesion without additional preparation requirements. These materials also have increased bond strengths, which helps to eliminate the catastrophic failures often associated with traditional crowns and other procedures. The biomimetically restored tooth mimics the strength, functions, and aesthetics of natural teeth. The course that we offer in restorative dentistry starts with an introduction into the biomimetic treatment approach, including foundational concepts, principles, and the advantages of this approach, including how it can revolutionize the way you approach restorative dentistry in your own practice. From there, we will move on to a hands-on course that will cover everything you need to get started with biomimetic restorative dentistry in your practice. This course will include techniques and materials with an emphasis on posterior restorations. In addition to the introductory and hands-on courses that I just described, there is an advanced course in biomimetic restorative dentistry that includes an in-depth literature review of the core science of this approach, including a review of over 25 articles that cover a wide variety of related areas. These courses can be taken as standalone courses over a couple of days, or they can be bundled together into a complete training course delivered over the course of 1 week. The complete training course option includes additional training on scientific literature, as well as cases on adhesion, materials, structural analysis, and stress reduction. As a follow-up to these courses, we also offer in-office mentoring to help you implement these advanced techniques in your own practice. We find that our system of mentoring helps to give dentists the confidence to take that next step into restorative dentistry. So now I am going to move on to talk about our courses about aesthetic dentistry, which is a natural complement to restorative dentistry since it requires less accommodation, incorporates acceptable biologic technology to increase the probability of long-term survival, as well as to mimic the pristine state of the natural dentition. Just as I previously discussed with restorative dentistry, aesthetic dentistry stands in contrast to cosmetic dentistry, which does not always emulate the pristine state of natural dentition. So,
now look at Extract 2. Extract 2, questions 37 to 42. You hear an interview about recent innovations in physiotherapy. You now have 90 seconds to read questions 37 to 42.
So today we have a special guest here to talk about innovations in the field of physiotherapy. I would like to welcome Sally Fields, a physiotherapist working with the NHS. Welcome, Sally.
thank you for having me. I'm so happy to be here today to share my passion with others.
So, before we get into innovations, I would like to talk about the role of physiotherapy in a person's overall health. So, how can it contribute to the health of the population?
That's a very good question. Physiotherapy takes a whole person approach to health and well-being. So with the population getting older and more people living with long-term conditions, it is necessary to use physiotherapy to help patients manage long-term medical conditions such as Parkinson's, asthma, cystic fibrosis and chronic obstructive pulmonary disease. Just to put the situation in perspective, 3 out of every 5 people in the UK have a long-term condition.
Oh, interesting. How is physiotherapy used to manage a disease like cystic fibrosis? I would never have thought of physiotherapy being used for that type of condition.
In the case of cystic fibrosis, regular physical activity and physiotherapy-led exercise help improve physical function, cardiovascular performance and muscle strength. Exercise may also aid airway clearance, slow the rate of lung function decline, contribute to an improved quality of life. In general, physiotherapy helps to build resilience in patients by building their capacity to manage their own health, and it also helps to enable people to regain maximum levels of mobility, function and independence following an accident or as they recover from an illness. Another interesting aspect of physiotherapy is the way it can be tailored to meet individuals' personal goals. Because physiotherapy requires a lot of commitment and effort on the part of the patient, establishing personal goals is very important.
Yes, it is definitely important for patients to play an active role in the management of a long-term condition.
Definitely, and that's why physiotherapists are starting to work alongside GPs. practice physiotherapists can help to assess, diagnose, treat, prescribe medicines, as well as manage patients' needs. This new model of care is part of a multi-pronged approach that has the potential to address the immediate crisis in general practice, as well as, of course, help deliver a better GP service as part of a modern primary care system.
Okay, so innovation in physiotherapy. What is the first innovation that you're going to talk to us about today?
Well, the first is robot-assisted physiotherapy. I will give a few examples of how it is used to give you a better idea of its current role and future potential. So, loss of arm function is a common problem after stroke, and there are ongoing clinical trials to determine to what degree robot-assisted training can help patients recover upper limb movement.
So is the robot replacing a physiotherapist?
Not at all. Using robots allow the therapist to get a greater understanding of the neuro-recovery process and also helps to build a rich stream of data that assists in ongoing patient diagnosis and customization of therapy.
Okay, I see. So can you give us an example of how it might work?
Of course. So, during robot-assisted training, the stroke patient sits at a table facing a computer screen and place their arm into the device. The therapist then asks the patient to undertake some arm exercises, such as moving between targets on the computer screen. If, let's say, the person is unable to move their arm, then the robot moves the patient's arm. But if the patient is able to initiate the movement, the robot provides adjustable levels of assistance to facilitate the person's arm movement, which helps the brain and arm to learn to work together again. As I said earlier, the clinical trials are currently being done on this type of robot-assisted physiotherapy, so there is a lot we still don't know about the potential of this therapy. Another type of robotic-assisted therapy uses what is called an exosuit, which is a robotic-powered exoskeleton used in people with weak or paralysed legs caused by stroke, spinal cord injury, as well as other neurological conditions.
An exoskeleton. So does that mean it goes over the body of the patient?
Exactly. It is placed over the legs to help with standing and walking. Specifically, it uses battery-powered motors to drive the legs. So the way it works when the patient is moving is as the person shifts their weight, sensors are activated that initiate steps, which can help the patient to relearn step patterns and weight shifts.
That is the end of Part C. You now have 2 minutes to check your answers. That is the end of the listening test.